Hi, it's Jenny B, NSWC, and today I want to talk about one of those pains in the butt that happens in wound care. There are actually several different types of wounds that actually can occur on the backside, and one of them, and the first one we're going to deal with in this series, is a pilonidal abscess or pilonidal cyst. So what they look like is commonly there's actually a very large swollen area that can happen somewhere along the natal cleft. So that's basically where the tops of your legs meet, or the top of your crack in your rear end. For the most part, they do have this big area that becomes swollen, inflamed, and hot, makes it very, very painful to sit down. And patients often actually present to the emergency department with this because they literally have a pain in their ass. This commonly actually occurs in patients that are between the age of 18 and 25, and most commonly in men. Only about 1 in 8 women does this actually occur in. And usually they have quite a bit of hair in the area, and it also tends to happen with people that have a bit of hypohidrosis or excessively sweaty, especially in weather like it is today. One of the other more common things that you will see is actually these small little, they look like really large pores. This is an enlarged photo of it, and these are actually a bit deeper, but they actually tend to start off with, they really just look like an open pore, and there's usually 3 of them that happen somewhere along in this natal cleft. So this is actually the top area, and it's a little bit higher up. So the reason this happens is, well, we do think that there is a bunch of hair that actually occurs within the cyst, that it becomes infected. It becomes, it's like an ingrown hair to the area, but then again, they can become chronic. So this sac, the little sac where your hair is, the hair gets stuck, and it swells and swells and swells, and then we have to end up doing what's called an I&D, or an irrigation and drainage, to help open, to allow the pus and the infectious fluid out. A lot of surgeons, a lot of physicians will actually give them antibiotics right away. We don't always. The surgeon's theory is that as soon as you've let out the infection of any abscess, they don't require antibiotics because you've given it a root out. So it is one of those things that, again, I don't always give antibiotics right away. We actually will wait and see, because the inflammation will actually start to reduce and decrease down fairly quickly. So the couple of surgical procedures you're going to see, this is what can actually happen with the pilonidal cysts after a long period of time, or after we've opened them. One of the other challenges are, this one was actually an incision that was all the way down, and you'll see how there's little islands of epithelialization where it's actually come together in between. This is the biggest challenge I do find with these wounds, and why they tend to continue to need surgery over and over again. It's because the rate pegs, the little pegs that once the tissue comes together, or just when they're sitting back up, they start to attach, but they don't do it evenly. So again, there's a large pit that it needs to actually heal from the bottom up, but it needs to heal in this direction. But what happens is it kind of does it in different areas, and so the bottom is not able to fully close, because there's still abscess underneath. So one of the things I do as a wound care specialist is I take one of the long Q-tips, and once there's a new incision, I'm always actually probing right to the base, and I run the Q-tip up and down. So it will actually break apart into those rate pegs that are attaching, above the area that would allow for another abscess to stay underneath. Another big piece with this is that we do want the patient to try to shower frequently. So we aren't always packing the wound. So when we just have the pilonidal cyst, when it's just the small open area where there's a small pit, yes, we have to pack those. But once they're actually to have a surgical procedure, which will actually open and get right down to the base of the wound, it actually preferred. This is a wound that does usually require some sort of surgical management, not just packing. For the most part, I actually like these wounds to use something called silver cell. The reason I prefer to use silver cell is for a couple things. Number one, silver cell is a hydroalginate, so it has hydrofiber, which is highly absorptive, more so than calcium alginate, but also combined with that calcium alginate that does have some hemostatic properties, meaning that it stops bleeding easily as well as very absorptive. And because there is silver in it, it's actually going to help to control odor and decrease the bacterial burden to the wound as well. So it will also, by packing and laying the silver cell in between, when the cheeks kind of come back together, they have something in between, and that will help to continue to encourage that granular tissue to come up and reduce those rate pegs from attaching. So one of the other things you'll note in any of the photos, you'll see that most of the areas are shaven. It's one of the things that can cause hypergranular tissue in the wound if the other hairs that are in and around actually will kind of poke into the wound and cause it to become friable or bleed really easily. So for the most part, we want to try to keep the area shaved. A lot of surgeons will actually recommend that the patient does have laser hair removal done to the area to help reduce that for ongoing maintenance of it. Oh, I lost my photo. So there are lots of treatments, which I will attach something from Connie Harris and Gary Sibbald. It's old, but it's still the most relevant teaching tool that I tend to use for patients to discuss with having a sitz bath, to, you can use a peri bottle, but to make sure this area is cleaned quite often. Often we're saying, oh, we want to leave wounds, for 2 to 3 days. These are not those wounds. This is one because of the abscess, because of the amount of bacterial load. Often I'm actually teaching patients how to do this themselves to be able to put silver cell down in here once they're able to get these open. So again, this is a procedure that the surgeon was actually going to do what's called a marsupialization. So he's going to actually cut all this out where the abscess was to get underneath where the abscess was and allow for then you have a nice fresh clean wound, no more abscess, no more bugs, no more bacteria, and now we want to get this healed. This being his actual bottom, it's not sometimes an area that we can vac. For the most part, I want to try to vac these wounds as long as we're going to be able to maintain an ongoing seal, but sometimes we are just really looking at trying to heal them secondarily. For the most part, the surgeon's actually going to try to close this, but sometimes if there's not enough tissue or tension or too much tension, they will actually leave some of the areas open. This again is because it was open previously, and then some of the areas healed over. But when he's going to take this big, larger piece and actually cut that whole abscess out, yes, they can have a larger scar, but then they don't come back. One of the other things they can do is actually what's called a flap instead of just a graft. So they'll actually take some of the tissue and move the tissue to actually fill in the dead space. Often they end up looking like this. So where they've taken some of they've cut out the abscess, and they've taken some of the tissue and moved it over and sutured it together. This one I also really caution that patients sometimes are like, oh, okay, great, it's a cyst. They treat it like just what a regular, nodular cyst would be, but it's not. It's because it was actually like a large cavity or sinus, an abscess that we've removed. These stitches are actually very, very fragile. Even though they do use mattress sutures or put some tension on them, the patient really can't be jumping back onto the couch or jumping onto when they sit. They have to be really cautious for the first 3 weeks after surgery. We actually do tend to leave these in a bit longer than the 14 days that we would with other sutures. So again, that's everything I know about a pilonidal abscess. As I said, silver cell tends to still be my main thing. I do try to not pack it and try to ensure that these areas all stay open so you have one nice long red line, because again, it often results in them requiring further surgery if you need to, and if we can prevent it just by running a Q-tip up and down it, it's going to make a huge difference. So once again, don't forget, the best wound is a closed one. Talk soon.